Welcome to Clinical Thinking Lab episode 4. Today's case is different from the first 3 episodes. This is not just about naming a diagnosis. This episode is about knowing when to change your mind. At first, this case looks like straightforward septic shock. But then new information arrives and the physiology changes. So the key questions becomes, do we keep treating the original diagnosis or do we update our thinking and treat the physiology that exists now? That is the main lesson of today's case. Let's begin. A 67-year-old woman presents with fever, productive cough, shortness of breath, and confusion. She has right lower lobe pneumonia and septic shock physiology. Her blood pressure is 84 over 52. Heart rate is 122. Oxygen saturation is 88%. So at this point, the case seems clear. She has infection, she has hypotension, she has hypoxemia, she has altered mentation. The initial working diagnosis is septic shock secondary to community acquired pneumonia. At this stage, the main problem appears to be distributive shock from sepsis. So my only reasoning is this patient has septic shock due to pneumonia. So the early management should focus on the basics: oxygen for hypoxemia, blood cultures and appropriate investigations, early broad spectrum antibiotics, IV fluids, and norepinephrine if hypotension persists after initial resuscitation. This is the correct starting point. At this moment, I am treating vasodilation and infection. Norepinephrine makes sense because septic shock is usually dominated by loss of vascular tone. In simple words, the pipes are too relaxed. So norepinephrine helps squeeze the pipes and support mean arterial pressure. But this case does not stay simple. Despite treatment, the patient worsens. Her blood pressure falls to 78 over 46. She develops oliguria. Her hypoxemia worsens, and bedside echocardiography now shows an ejection fraction of 20% with diffuse hypokinesis. Her old ejection fraction 6 months earlier was 60%. This changes everything. Now the problem is not only vasodilation, the heart is also not pumping well. So this is no longer just distributive septic shock. This is now mixed shock. Distributive shock plus cardiogenic shock physiology. And the key clue is the echocardiographic finding. Ejection fraction 20% with diffuse hypokinesis. The updated diagnosis is mixed distributive shock and cardiogenic shock, most likely due to sepsis-induced cardiomyopathy. This is where I have to be careful with my words. The patient has acute heart failure physiology because the cardiac output is poor, but I would not immediately label this as chronic heart failure because the old ejection fraction was normal and the hypokinesis is diffuse, not regional. Regional wall motion abnormalities will make me worry more about myocardial infarction, but diffuse hypokinesis during severe sepsis suggests global myocardial depression from inflammatory mediators. So the better term is transient myocardial dysfunction due to sepsis-induced cardiomyopathy. This matters because the diagnosis changes the management. If the pump is now failing, simply increasing norepinephrine may not be enough. Now, the management must evolve. We still continue antibiotics and source control because infection is still the driver. We also continue norepinephrine because she still needs vascular tone and mean arterial pressure support. But now we add dobutamine because the heart is not contracting well. Norepinephrine and dobutamine do different jobs. Norepinephrine supports vascular tone. Dobutamine supports cardiac contractility. A simple way to remember it is norepinephrine squeezes the pipes. Dobutamine strengthens the pump. A common mistake would be to keep escalating norepinephrine when the real new problem is poor contractility. This is the ICU principle. The treatment must evolve when the physiology evolves. 48 hours later, the repeat echocardiogram shows that the ejection fraction has improved from 20% to 55%. This rapid recovery is very important. It supports the diagnosis of reversible sepsis-induced cardiomyopathy. If there were a large myocardial infarction causing permanent damage, we would not expect the ejection fraction to recover from 20% to 55% in just 48 hours. So the timeline itself becomes diagnostic. Severe sepsis cause temporary myocardial depression. With antibiotics, source control, norepinephrine, dobutamine, and improvement in the inflammatory state, the myocardium recovered. This is why sepsis-induced cardiomyopathy is different from chronic heart failure or irreversible myocardial necrosis. The recovery tells us that the process was reversible. The biggest lesson from this case is do not anchor to your first diagnosis. At first, septic shock was the right diagnosis, but later the echo showed new pump failure. So the diagnosis had to change. And once the diagnosis changed, the treatment had to change too. The second pearl is treat the physiology that exists now, not the physiology you assume at the beginning. Initially, the patient needed antibiotics, fluids, and norepinephrine. Later, she needed ongoing norepinephrine plus dobutamine because she had mixed shock. The third pearl is changing your mind is good medicine. The goal is not to be right on the first attempt. The goal is to keep updating your diagnosis whenever new evidence changes the physiology. This is what I learned today. In clinical medicine, the patient changes, the data changes, the physiology changes, and our thinking must change with it. This is Clinical Thinking Lab episode 4, one case, one evolving diagnosis. See you in the next one.